Hi, how are you?
I'm very good, thank you. How are you?
Good. It's good to see you in person. I see you all over social media and I've devoured your book. So it's very good to meet you finally.
Oh, well, it's lovely to meet you too, and that's lovely to hear that you liked the book.
I really, really did. I was intrigued. I knew I wanted to read it because you're an endocrinologist, and I haven't seen anyone in this space. Obviously, I don't know everyone, but I've spent a couple of years watching, and I haven't seen any endocrinologists speaking out publicly. I'm sure there's tons seeing patients, obviously, but you're very unique. You're unique in the UK, you're unique in the world, I think.
I think in the UK, quite unique. Probably not so much in the US, but still in the US, this field is in terms of direct to public education. It's much more provided by general practitioners and gynecologists. But I think there's a bit more in America. But the thing about endocrinology is that it's quite an academic specialty. So most of my colleagues are doing research and very detailed scientific or clinical research. And that is very time consuming. So they couldn't then, do what I'm doing. Whereas I'm a clinician. So I see patients day in, day out. So what I do clinically lends itself very much to expanding that information on, these sorts of in these sorts of spaces. So I think maybe it's just because of the timing, the way the world is, the way social media is developing. I think more endocrinologists should be in this space, and I think they will be ultimately over time, because I think that's the way to get the word out and balance the conversations that are on social media about all different hormone type topics. I think it's really, really important, because other specialists who talk about hormones will come in from a slightly different angle. And the thing about endocrinologists is that's all we do. We just do hormones and we love hormones. So, hopefully I will be bringing something to the table that isn't there, which is good.
Well, that's why it's crazy. There aren't more talking about it. Like, you're the actual specialist. But what I'm curious about is how in the UK, how do people end up in your office? Like when you go to your GP and you're having perimenopause symptoms, are they referred to you and is that what normally happens, or?
The answer is they'd end up in my office with difficulty, because it's a small specialty, so there's not many specialists like me. When I worked in the NHS, I'm not currently working in the NHS, but I did for 27 years. And in my consultant post, I had a particular interest in reproductive endocrinology, and my department specialised in reproductive endocrinology. It's a big, big name. And reproductive endocrinology is basically all the hormone imbalances that women have, right from puberty to menopause. So I deal with puberty issues, I deal with conditions of younger women like polycystic ovarian syndrome and premenstrual disorders such as PMS and PMDD that some people may have heard of, and then perimenopause and menopause. So I had a particular interest in that. And endocrinology, although you sort of think it's hormones and, there's not too many hormones, actually it's very super specialized. So my research training many years ago was in pituitary endocrinology, which is kind of the master gland in the brain, which links with all the different hormone glands. And then in my clinical career, I have done an awful lot of pituitary work because that's what I trained in terms of research. But that also links very much with reproductive and thyroid and adrenal problems, because the pituitary controls those glands. So I'm kind of a supra specialist. GPs often aren't even aware they can refer. Often they try not to refer. I think perhaps sometimes those referrals aren't received happily by some endocrinologists who are mainly doing diabetes or mainly doing research. So there's lots of different reasons why. And actually, in terms of the menopause space, I don't think every woman should have to see an endocrinologist, because I think GPs should be trained in it. It's a common endocrine condition, like, there's other common endocrine conditions like diabetes is a common endocrine condition, and we can't have every patient with diabetes seeing an endocrinologist. There just aren't enough of us. The training is forever. Do you know what I mean? So you can't train enough doctors forever to see every patient with those conditions. So I want to improve training of GPs, general practitioners, to be able to help all women, not just those women who are lucky enough to fall into my clinic by accident or with difficulty.
What drew you to the specialty when it's like so complicated to finish?
Yeah, I mean, I think that was it. When I first qualified, and I did training in several different specialties, and I trained through, cardiology and rheumatology and neurology and dermatology and, gastroenterology and, respiratory medicine, all of the specialties. And I found more really interesting. And then right at the end of my general postgraduate training, when I was doing my exams to become a hospital specialist, which in those days you did kind of fairly earlier on in your training, about 3 years after qualifying. And the last job I did was endocrinology. And I had done loads of specialties, and I just thought, oh, wow, this is really interesting. And in those days, the exams, we had written exams, and then we had written and clinical exams. And endocrinology was always a really popular topic because it was always the difficult conundrums of medicine. And I just loved it. I loved the just all the different conditions. I just found it just set me alight. And I think that's what happens. You find something that you're passionate about, and that's really important with any career, I think, isn't it? That you really enjoy doing it. So it was the last specialty that I trained through when I was doing my general training, and I just thought, this is it. And then I was lucky enough to get a training post. It was in London, actually. I did a lot of my clinical training in Southeast Thames in London. And no, I've enjoyed it. My career, I'm very lucky in that I have a specialty and a job that's incredibly interesting. And most people who I speak to do say it's interesting.
You don't hear very many endocrinologists. What do you see? You mentioned social media and bringing balance to social media. What would you say are the biggest problems you see on social media when people are talking about hormones? In things that are incorrect, factually wrong, just
well, there is, I mean, in social media there is a problem that often there's biased information on all sides, and you tend to see through advertising, through the types of accounts you follow, you tend to see what you want to see. So if you want to see something that says a particular treatment is brilliant, you'll be bombarded with that, with advertising and with suggestions of who you might follow. And equally, if you think another treatment is really good, you'll be bombarded with that. So you tend to get biased information, and so it's not always, you don't, if you're not in health, if it's health information you're looking at, you can often get quite biased information. So I think that's a big problem. And the second problem that I'm noticing very much at the moment is that it's quite combative. People are getting quite angry and upset, and that's never good. If you're trying to sort something out in healthcare, getting angry is going to put your stress levels up. Well, to me, that's counterproductive. But people are sort of saying, well, women should be doing their own homework and finding more out about what they need in terms of their health. So that's patient shaming. That's, saying, it's a woman's fault if she's not well because she hasn't done her research. And actually but then the other side of the coin is the GPs are fobbing women off again and again and again. We all hear it. I hear it in my clinics. Women get fobbed off and told there's nothing wrong with them, or they need an antidepressant when they've got a hormone problem. And that needs to be addressed. And there are clear-cut problems, but there's sort of a disconnect in how this is being viewed, how this is being addressed, and where the solutions come from. The solutions are not going to come purely from social media. The solutions are going to come from healthcare delivery on a broader scale, and it's always political. So, you need the politicians on board to change healthcare delivery and structure and culture.
No, they were discussing that in British Parliament just this week, right? So we'll see.
They were.
Yeah. What do you think about that whole approach?
Well, I think it's really a positive thing that it's being discussed in Parliament. And I think it is being recognised at a high political level that, women are not sick when they go into, it's not a disease, but it's having a massive economic burden on, you know, women in employment, women's lives, relationships, productivity, and symptoms. So it is, you know, you can get ill health from symptoms. So I think they're recognizing there's something wrong, but they don't really know what to do. And again, they're getting very mixed messages from different factions, as it were, because there's so much. So it's polarized. You know, some people are saying, you know, every GP should just give every woman HRT, you know, as soon as she gets a hot flush, and should stay on it forever, which is how it was actually in the 1990s, before the NIH study flagged up concerns, particularly with older women being left on treatment and not being monitored. And then other, you know, people, GPs are saying, well, you know, I've given HRT to my patients and they just end up it doesn't agree with them, or it causes problems, or it causes side effects. And that's also true. These are all truths, but, you know, everybody's got their own different truth, because we're all different. So some women will do well on one particular, you know, mode of treatment, some will do well on others. And there's a skew of people on social media. I mean, there's 13 million women in menopause in the UK, and very few of those are on social media, and very few of those are on HRT actually, and many of them are actually okay without it, haven't really thought about it. I see loads of patients in my clinics who say, I say, are you on social media? Because I say, you know, you can follow me. No, I'm not on social media. Stay away from social media. So lots of people are not on. It's a small proportion, and that again is a biased group. You know, it's a self sort of selected group. So it's a messy issue. So I think the politicians don't know what to do. They don't know. They're getting so many mixed messages from different, you know, groups, that I think that's where we're at. We need the politicians to work out what the best approach is. And I mean, as I always say, and you'll have heard me say this, we need a balanced approach. We don't want extremes. We don't want to say, right, this is and you know, we have evidence about safety and risk, but there's also looking at individual preference and individual, you know, requirements and needs for women.
Yeah.
And there's no substitute for understanding that individual situation. You can't give a one size fits all and expect it to work, because it just doesn't. It doesn't in any type of healthcare, really. Personalized medicine is something that is what we really need. And it's not forthcoming because we just want everything standardized because it's cheaper, but it's not as good.
Well, I'll get more into what like your approach is, but I was going to say that from the outside in the UK, things are moving quickly. You have celebrities talking about it. You have Parliament. You have it in the high school curriculum. You have the Channel 4 Davina McCall documentary. But from the outside, it seems like it's HRT all the time. Hormone therapy. Everyone calls it HRT. HRT all the time. And like, that's what I'm saying. The impression I'm getting from the media, whenever there's a story from a celebrity, it's like, I was wretched and then I took HRT and I was fine. This is my impression, but that's the theme of that's the narrative. And then social media it's all about hormone therapy. And that documentary, I wasn't ever able to see it, so I don't really like talking about it. But there were nutritionists and mental health advocates saying, you know, it seemed like it was just about HRT. So what I'm saying is, in the UK, it seems like that is getting more weighted. What do you like? What's your perception? Because you're in the middle of it, and we can always say there's nothing wrong with HRT. In your book, what I love is you say it's an accessory rather than an original approach. But just to speak to that issue in that situation in the UK, do you see that too?
Yeah, so it's a tricky one because, and I say as an accessory because not every woman will choose to have that or need to have that, but many women do. And I've got, you know, huge numbers of patients who I treat with HRT. I'm not anti-HRT. It is one arm in our armamentarium to manage the complex set of symptoms that come in menopause, but it's not the only one. And it got really, really bad press in the early 2000s because of some big research studies that most people are now aware of that were in the press that said HRT is evil, basically. You know, it caused lots of different horrible things. And that those studies were flawed because they didn't take into account subgroup analysis. They didn't look at the differences in how HRT affects younger women versus older women, looking at risk benefit ratio. And we now have that information. So, you know, before 2000, every woman was given HRT, and they were put on HRT when they had their first hot flash, and then they stayed on it forever. No one monitored them. And some of those women after 20 odd years came to harm. And that's what kind of came out in that research study. But what also came out was that the younger women who were really struggling with symptoms, actually, if they were really struggling with symptoms, HRT often helped, it not as a sole treatment. And I always say this, you know, if you've got a stressful, horrendously stressful life, you've got a relationship on the rocks, you're eating a poor diet, you've gained, you know, 20 pounds in weight because you're not exercising and you're under stress, your nutrition is poor, all of those things. If you take HRT, it's not going to fix your well-being, because all of those other lifestyle aspects are very, very important. But if you were addressing your lifestyle and you take HRT, it will make a difference, particularly in those first few years of that perimenopause, when the symptoms can be really problematic. The commonest, there's many symptoms, but the commonest symptoms are hot sweats and night sweats, fatigue, insomnia, and anxiety, and sometimes muscle aches. There's lots of different symptoms, but for those symptoms, HRT can definitely help with your sleep quality and your anxiety. So it can be helpful for the women who are having those symptoms, but we shouldn't be saying everyone should go on it and then never check it again, because that's where we're going backwards. Then we're just saying, well, okay, and then we'll say, oh, and 20 years later we're finding lots of women coming to harm because they've been left on HRT and not discontinued it. And the other side of the coin is that many women try HRT and they struggle with it. I had every clinic, I will have patients and they'll say, I'm not right, I'm not well. And they've tried 4 or 5 different preparations and different types of HRT and combinations, and they're still not feeling well. And it's often because of the X factor, the other factors, the stress factor and other lifestyle factors. So I know, and I've been seeing women for, over 3 decades with menopause, that HRT is not a panacea. And the media, it's our healthcare culture. We want to see a quick fix. The media wants a headline. I was in menopause, I had HRT, I was amazing. That's the headline. But the truth underlying that is much less sugar-coated. It's a sugar-coated headline. Yeah. So, but it does make, I think it's problematic, because women who want HRT who can't get it from their GPs, then that makes them really angry. Women who've had HRT and can't get on with HRT think, where does that leave me? And it's upsetting and stressing everyone out. And actually, the truth, the reality, which is that balanced reality that no one wants to talk about because it's all very sensible and it's about looking after yourself and your lifestyle and, taking a view on hormones and trying them and not expecting the world. It's not a good story for the media. You're a journalist, no one wants that story. So it never gets there. Right. And then the poor politicians are going, I don't know what to do. I don't know what to do.
I don't blame them. Because they're hearing horror stories and they're probably hearing from all sides. And then of course there's always this is what's the problem with it being so polarized, is on the other side, you have, I call them like HRT Helens and natural Nellies, because it's just as damaging, right? It's just as damaging when you have someone saying like, you can balance everything with like chakras and whatever. You can with you as your book states, your lifestyle has a huge, but this natural side that says it's terrible to go on hormones and you shouldn't do anything medical at all isn't helping either, right?
And one of the things that I say in my book is that we must all find our own menopause management path, and that's not going to be the same route as everyone else, and no one should be judged. If they choose to have HRT, they should not be judged. If they choose not to have HRT, if that works for them, that's fine. But what shouldn't be happening is, if you are somebody who HRT is amazing for, you shouldn't be saying, because it's good for you, you then demand everyone in the world, every woman, when she has her first hot flash, to have the same treatment as you, because those women are not the same. Equally, if you're incredibly holistic and you're doing the natural stuff and it's working for you, that doesn't mean it's going to be working for somebody else who's having terrible menopausal symptoms. And we know that our biology, everyone's biology is different. Some women will get awful sweats and flushes, really bad. Some women will get awful anxiety, others won't. And so you can't compare your own narrative and your own experience to everyone else's. So no one should be judged. And if a woman chooses to stay on HRT because every time she tries to stop it, or every time her GP's tried to make her stop it, she's felt ill, that's her decision, as long as she understands her risk benefit ratio at each time in her life, you know, in each stage. And I have many patients who are on HRT who are much older who say, I'm not coming off treatment. And my job there is to say, right, okay, let's just check, you know, are you up to date with, you know, your blood pressure checks and, you know, mammograms and all of those safety checks that will just make sure that there's not an increased risk with HRT. And, you know, in most women will be all right taking it for many years. Some women won't. And the problem is you don't know it. And so if you don't have it checked, if you don't think about this carefully, you can be playing a little bit like Russian roulette with your health if you're not gaining the benefits. And the benefits are definitely greatest in those first few years around the perimenopause, with bone health and well-being and symptoms. And later the risks start to go up each decade. So after 60 and then after 70. And for some women, the risks will never be a problem. And for some women, it will. Cardiovascular risk, which is a big risk for all of us as we get older. Those are the risks that get higher as you get older with HRT. But it's very individual. So I just don't think anyone should be judged, but we shouldn't all expect that what works for us is going to work for everyone else. It's not a one size fits all.
You mentioned in your book, I haven't heard anyone mention this, that when you get older, when you come off of it, if you choose to come off of it, you're probably going to have some symptoms again. So that was interesting to me. Or you could.
Well, no, if you come off it suddenly and abruptly. So what I find is I can have women who are maybe heading towards 60, for example, and they'll say, look, my symptoms of menopause are much less severe now. I've got, you know, my life is less stressful, and I want to see if I can come off treatment. And so two things happen, actually. Usually either they just decide to stop it. They just go, I don't need this anymore. And they stop it cold turkey. And then they come and see me with, you know, sheepishly going, well, I stopped it and all my symptoms go. I said, how did you stop it? Because I always tell my patients, tail down gradually so you don't get that cold turkey effect. And usually if you tail down very gradually, it's seamless and the balance is maintained. If you stop suddenly, you can get rebound symptoms. And so some women do that and they'll go, I know, you told me that it would, but I just thought I was fine. And so then we tail off it gradually. But then the other one, which is awful, is when a woman says, well, it was around my 60th birthday and my GP just said they're not prescribing it anymore suddenly. And so the treatment is stopped and they're refused prescriptions, and that is probably worse because that's even more stressful, because that isn't even something that a woman has chosen to do and then found that it wasn't right. It was like enforced, and that is frequent. And again, that's wrong. It's wrong. There's no International Menopause Society that says stop HRT abruptly without a woman's consent. And so, there's lots of stuff that's not right. And I think women need to be empowered. It's not helpful to make women super angry about their GPs, about their healthcare, because it's stressing them out. We need to improve the delivery of healthcare for every woman, for women's health, and in the UK, it is different in every country, as you know, but in the UK, we have this amazing resource of primary care, which is very overstretched, but they're very good if they're given specific, specific instructions on what they need to do. So, for example, a few years ago, I mentioned diabetes is a very common endocrine condition, and it used to be managed by endocrinologists in hospitals. And then this was sort of 20, 30 years ago, then we got an obesity epidemic and a diabetes epidemic. And so there was more and more people with diabetes. We couldn't see everybody with diabetes. So the government recognized this and said, No, we want GPs to manage diabetes. And we all said, oh gosh, but that's a big ask because we're trained in hormones and we know about, and actually the GPs did it. They were mandated to do it, and they do it. And for some people need to see a specialist, endocrinologist, diabetologist, but most people are okay with management from their GP. And the same has happened in the UK with asthma management. All asthma patients used to be seen by specialists, lung specialists. Then it was like, this is not possible. We can't train enough lung specialists. So the GPs do that. And there's lots of support from the practice nurses, and that works well. We can do it with women's health and menopause management. Women's health and menopause management is not as complicated as diabetes. Right. So it can be done, and it's not even going to be difficult, and it would be better care at lower cost. We wouldn't be spending money on unnecessary antidepressants, and we wouldn't be seeing the economic effects of women leaving their workplace, amazingly skilled and trained women leaving because they aren't able to cope because they're not getting the support. And that's a passion of mine. I see lots of men leading this world, and I see lots of women leading right the way from high school through university, through early careers, then they disappear. Yeah. And it's wrong, and we need to change that. So it's not just women and symptoms, it's economies, and it's our world that matters. It's a very big picture, and so it's better care at lower cost if we actually just mandate a bit of better care from the GPs.
And if they do it, they'll get better at it, and they'll have guidelines, right? Like, they're not going to get bad. We all have worked with that person. They call it in the US the menopause management vacuum, because the GPs don't want it, and gynecology and internal medicine they're busy too, right? So, but if you make them do it, we've all worked with that person who doesn't want to do that one job. No one wants to fix the photocopier. That's like, yeah. But if you make them do it, then they'll do it. It makes sense to mandate it.
Well, it's not even so much that they don't want to do it. And I don't think the GPs were too keen to manage the whole of diabetes when they were mandated to do that a few years back. But the thing about menopause is that GPs, it's the unknown, but GPs are highly skilled, highly intelligent doctors, highly trained. And it's not a huge amount of CPD, continuous professional development, so update, that they need to do in order to get good at it. We know that because there's lots of brilliant private GPs on Instagram, for example, who have done a diploma over, it's a few months of training, and, it is specialist training, and it's probably more than every GP could do in every GP practice. But the training that the British Menopause Society provides to GPs is brilliant. And at the end of that training, and it's not like my training, 25 years or whatever, it's a finite amount of training, and they're highly expert at managing menopause at the end of that training. And that's super expert. I mean, even if you could have one GP per commissioning group who had that level of training, and then other GPs who were doing slightly lower level training and getting the nurses to do training. The nurses can do the training as well. It's not difficult. And actually, the reason GPs don't like it is because they haven't done the training in it. And if they do the training in it, they will enjoy it because they're good at it. And it's interesting, actually. So, and they will gain a huge amount by helping their patients. At the moment, they don't like menopause because they give a woman an antidepressant and she gets angry with them saying, I'm not depressed. Right. So it's a lose-lose situation. If the GP says, right, these are all the things you need to do, here's some things you can do for yourself. If you're already doing all of those things, or your symptoms are severe, here, have some hormone treatment. This is the best, safest type. The GPs will love managing menopause if they do that.
Okay, so on to lifestyle. It's so interesting because you went into this field and then you had breast cancer in your early 40s, and you were then shunted into menopause, and you couldn't use any hormone therapy. You had to work this all out for yourself in hyperspeed, I imagine.
But it wasn't really, because it wasn't really having to work it out in hyperspeed, because I'd been managing women for years and years and years. And I knew everything that all my patients had told me about the symptoms. I'd obviously studied menopause management, studied all the things that you can do for yourself for symptoms. So I had that understanding already that I'd love every single woman to have about what's happening here. Oh, I know exactly what's happening. I'm feeling that symptom because of this. The problem for most women is it hits them when they're busy in their life. They're not endocrinologists. They don't know what's going on in their body. And they just think, this is awful. And the symptoms can overflow and they don't know what they are. And it's terrifying. And the whole thing can escalate out of proportion. What happened to me was that for me, it was like, wow, I've been managing menopause and telling all these women what to do for so many years. And I've studied it all and I know all the theory, but I've never done it in practice. Here's my opportunity to understand this whole narrative really personally. So I took it as a challenge, and everything that, and it was wonderful actually in many respects, because everything that I talked to patients about, I could say, right, I know what that hot sweat feels like, and I know what that anxiety and that bursting into tears. I remember bursting into tears in an occupational health meeting because I went back to work after 4 months after I was diagnosed with cancer, and I was in chemical menopause. But I think my estrogen was dipping at this meeting, and I don't know what this occupational health doctor thought of me, but I suspect it's quite similar to when a woman goes into her GP and says, I think I'm in menopause and I need something. And she's just, you just can lose the plot. And I never cry ever. My kids think I'm mad because it doesn't matter why, they never cry. But I was sobbing in this meeting. I couldn't control it. And, but I knew that it was actually time-wise the peak of my estrogen dipping after I'd had my chemical menopause injection. And I wasn't depressed. It was just the hormones crashing down. And, and actually after a couple of weeks, I kind of felt better. But I felt sorry for the poor doctor because they didn't know what to do. They just went, I think you might need a bit longer off. I still went back to work. But I really understood what women are talking about. I know what they're talking about, but I also knew that it was all manageable. And for me, if I hadn't had breast cancer, I'm sure I would have, and if I'd have had severe symptoms, I would have said, right, let's go for some HRT. I would. I don't think there's a problem with HRT at all. I think it's great. But for me, I had an estrogen receptor positive breast cancer, which meant that HRT, I might be fine for a few months or even a few years, but these types of cancers can come back several years later. And that, you might take the estrogen and think, oh, I feel better for the first few months. And you don't realize that that's feeding silent breast cancer cells that can come back 11 years later. I remember a nurse who I worked with in the NHS many years ago. She had a seizure at work. It was in a sort of an emergency unit. She was an emergency nurse, and she had a seizure, and it was all very traumatic. And her brain was riddled with secondaries from the breast cancer that she'd had 11 years before, and she'd been absolutely fine. So I knew, and I've worked, as you know from my book, in oncology, over the years as well. So I knew I wasn't going to take estrogen. And it was a bit of a gift, really, because I did manage completely great without any hormones. Wow. And having tamoxifen, which is a drug because I stayed on tamoxifen, I didn't go on aromatase inhibitors, even though I'd gone through menopause. But tamoxifen can cause menopausal symptoms as well. I'm due to finish it because I'm actually 10 years out from my diagnosis this month, actually on the longest day. So yeah. I've got my life very much back on track without hormone treatment. And it almost forced me to pursue healthy lifestyle approaches. It sort of almost gave me that agency to say, no, I have to do my exercise because that's, keeping my adrenals healthy and keeping me, fit and strong. I have to attend to my nutrition. I have to try and manage my stress and not overcommit. And I do all of those things. And it's almost a gift because I think actually my quality of life is better now. And I'm through the menopause. It's better now than it was for many of my premenopausal years when I was perhaps not really looking after my health, which many of us don't. And women put themselves second or third or fourth or last, they don't put themselves first. And I always talk about self-care because if you don't look after yourself, you're not going to be that person that you want to be for those around you. So self-care is not being selfish. But, I think yeah, in a way it was a gift, because I don't have any hormone treatment, but I feel good. You know, I don't think I feel better than I felt in my 20s and 30s. I was so busy working as a junior doctor and then training and doing incredibly long hours. And now, you know, I still work long hours, but I think my lifestyle has helped me to be more productive. I think you are more productive if you look after yourself. So it's a win-win, really.
Well, this is sort of hard for people to wrap, and even me, it's hard for me to wrap my head around now when I let stress come in, or I exercised too hard when I was tired, or I let myself get tired. And I keep reminding myself, like, you're going through something. So am I right in this? You're going through something important that's altering your hormones. So you really can't afford any leeway in any area, right? Like you just can't have a terrible weekend of food or drinking. Like, these things, we can't really handle them. But why?
Well, you can, but you'll get payback. So it's because your equilibrium, your body balance is being impacted by the hormone changes. So if your hormones are all over the place, that equilibrium isn't robust and strong. So if you push it, I mean, one of the things I often describe it as, and this is more with fatigue than anything else, is that you can push yourself to do too much, have a stressful, you know, set of work challenges, or go out, you know, on a bender, drinking too much, going out late, or whatever it is, or doing too much exercise, overtraining. And you can do it because your body can respond in that acute setting. The adrenals will force all of those sort of stress hormones to get you through that. And it's like going to the bank and getting a week's money out of the cash point, you know, the wall banks, and you put your card in and it gives you a week's worth of money, and you spend it all in one go because you want to have a big splash out. And then you go back to the bank the next day and you go, I want some more now. And the bank says, no, you've used it all up and you're not getting any till the end of the week now. So you're there going, but I've got nothing left in the bank. I've got nothing left. And the bank says, tough. And sometimes you end up having to pay back with interest as well. So the energy is lost because your equilibrium, your balance isn't there. You then you use what you haven't got, and then you can crash. So it's not that you can't do it. And sometimes, you know, people will say to me, I've got this big wedding coming up, your friend's getting married and it's a really good friend. And I say, look, just accept that you'll be a bit wiped out after that, but just try and not do too much before and around that time. And the other thing is, if you do implement healthy lifestyle approaches, like, you know, your good nutrition and your exercise, you will build up your level. So you'll be able to do more before it hits you, before fatigue or sort of that sort of burnout feeling hits you. But also, and I talk about my own experience, and I guess there's probably a bit of luck here and there with lots of things. Symptoms are different for different people. So some people will, I always talk about the hot flushes, they're the commonest ones, but there's all different symptoms. Some people will do everything from a lifestyle perspective and they'll still get severe anxiety or severe, you know, hot flushes or night sweats and insomnia. And so it seems crazy if they can take HRT safely that they wouldn't try that to see if that helps. But the key is not to expect that if you've got all these things going on and you take HRT, it's going to be a magic wand and it's going to solve everything, because it won't. But it can be very good as part of the picture if you can take it safely, you know. But it's just like with everything in the world, nothing is straightforward. And with health, the human body is not simple. If it was simple, we wouldn't have such long training. And, you know, something like my specialty, it does take years and years because it is complex, understanding all this balance and how different systems interact with each other.
Then thank you for the bank analogy, because it cleared it right up for me. And I've made too many withdrawals from the bank since I finished the book. And it's like clockwork. Like, I count back, and it's not just, I went out and I ate food. It's like a tough conversation I had, a friendship trouble, like things piling up in my life. I just now, if that on top of my birthday weekend flattened me for a couple of days. And at first you're always like, what's going on with me? Am I dying? And then I'm like, no, this is your body. You can't do, you know, you had too much. You've got to. So I am so grateful for that. Thank you.
Well, it is, because this sort of thing is a modern woman scenario. I mean, all that you just talked about, 30 years ago, even this sort of stuff, we didn't, there was so many things that would not have happened. We didn't have social media. We weren't connected with everyone and everything all of the time. So even just something like a birthday 30 years ago, I know it's a big birthday because I saw your Instagram, but 30 years ago, you might get a few cards and a few presents through the post, and you might do a little meal or something. You might even have a little party one night. But now it's very different. You're trying to see everybody, speak to everybody, and it is the stress and the challenge to your energy balance with that sort of thing is fairly unique. And we just expect our bodies to take it, and our bodies can't.
It's interesting to hear a medical doctor talking about if your relationships aren't good and you need to look at that. And that's obviously, we know how hard it is to end everyone knows how hard it is to end a relationship, or to look at a relationship in the face that's not working. But can you explain why? I mean, that's just the stress, isn't it? It's just the stress of ignoring a relationship problem. Is that part of the lifestyle change?
Well, so there's a couple of things in that. When women go into perimenopause, it's often from 45 years of age and onwards. It's very individual, but at 45, women's hormones might be starting to fluctuate a little bit. And whether it's linked or not, we know that, I think it's 1 in 3 still relationships break up, and the timing of that breakup is often, when the couple have sort of gone divergent in their lives. A woman might have her career, man his, and they're going in different directions, or a woman might not be working and a man working, or the other way around. They might have had kids, the kids may be grown up. And during the 40s is a very, very common time for relationships to break down. So relationship breakdown is a major life event, and that sort of major life event creates a huge amount of relentless stress on the body. So if you've got additional stress, that it affects right from the hypothalamus in the brain all the way through, and it affects your production of hormones. We know that through any sort of stress. We know that, in wartime, when there's huge stress from war times, we've got data studies showing women's periods stop, younger women, because the stress impacts on hormones. And in perimenopause, if you're going through a huge amount of relentless stress, so that's not fight or flight type stress that we're programmed for, but it's relentless. It impacts on our hormones. So you've got, if you're going through a relationship breakup, which many of us do, it's incredibly stressful. Unfortunately, that can have a knock-on effect on your hormones. You're then feeling lower, less motivated, less able to try and, do any sort of arbitration with your partner, and the partner might not be on board with that. And it's just a vicious cycle. So I am a conventional doctor, but all my colleagues call me holistic. I do see the bigger picture, and I will never apologize for saying that stress and lifestyle factors have an impact on physical health, and the mind and the body cannot be separated. They are inextricably linked, and anxiety from the limbic system in the brain impacts on your adrenal response, and vice versa. So I don't apologize for saying that, stress will make your health worse. And if you're going through menopause, it will make your menopause symptoms worse. And of course, I've got stress chapters in my book that explain something that's very well known in science. It's described as allostatic load, which is where if you keep being stressed for your whole life, it causes dementia, it causes osteoporosis, it causes vascular disease, diabetes, obesity, and increases cancer risk. Chronic stress is very bad. So, and I think when you understand it, we can't take stress away from our modern world. We can't all take away stress. I've got stress. We've all got stress. But if you're conscious about it, you can make small changes to reduce the impact of that stress on you. And that's the difference between, I think, maintaining your health and well-being and losing it. Because if you have no idea and you're chronically stressed, and some small tweaks that you could do, you're not doing, it's the difference between feeling good and feeling awful. And, no amount of HRT is going to take that bit away.
Right. It's interesting that you mentioned the stress and then the link to, well, there's the big three that we're all terrified of, right? We're all terrified of dementia because the rates of women cases are so much higher than men. Osteoporosis and cardiovascular. I mean, we're scared of cancer too. But what you hear a lot is that for these big three, if you go on hormone therapy early, they have a preventative effect. But also you're saying lowering your stress, and I know exercise and diet and all those things directly relate to your ability to lower your risk for that. So if you're not on HRT and you're reading that maybe HRT will protect you from these things, it all feels irresponsible maybe not to go on them. Like, how can you help women sort of balance that out?
Yeah, so I suppose because I've got a science background and I've done an awful lot of research. I've got so many letters after my name, it's embarrassing. And I've critically appraised lots of research studies. And so the thing about a lot of the research on HRT is that the women who enroll in research studies on HRT in the past, historically, the women who have been enrolled in studies are motivated, often middle class, often already doing regular exercise, often already having good nutrition, and are generally not overweight because they would be excluded from the studies. So, you know, the research studies showing results of benefits of HRT may be confounded or conflicted by other factors, confounding variables that are actually more responsible for the outcomes than the HRT itself. We know HRT helps bones. So then we look at more detailed analysis. So with HRT, it definitely strengthens bones. Estrogen strengthens. So in men, testosterone works to increase bone strength through estrogen receptors in bones. So estrogen is very good for bones. So women who have an early menopause, say, you know, in their early 40s or before that, they really do benefit from the bone health perspective, because having HRT in those years up to sort of 50, 55, 60 will strengthen their bones. And so when they get to 80, they're less likely to have a fracture. But there are many, if you go into a normal healthy menopause at 50, 55, something like that, there are many lifestyle measures that can maintain your bone health after that period of time. So, and I talk about them, weight bearing exercise is very important, having good nutrition, so making sure you've got good calcium and vitamin D intake, and then attending to any additional medical conditions that might predispose to osteoporosis. So it's quite easy to work out who's going to be more at risk of osteoporosis in the longer term and who isn't. And younger women benefit from an osteoporosis perspective for sure. So regarding cardiovascular risk, if you have healthy blood vessels, which younger women do, and then you take estrogen away, it accelerates blood vessel disease. So we always try to give estrogen back to all younger women who have a premature or early menopause. But when you go beyond 60 years of age, most women will have a little bit of heart disease. It's part of the aging process. Most people at sort of 80, 90, if you do postmortem, when we look inside the body after death, you can see a little bit of blood vessel disease as part of aging in many or most people. And none of us know who we are. We don't know if it's going to be, you know, if I'm going to have perfect blood vessels when I die or not. You know, you don't know, you can't, because we're all different. So unless obviously if you're smoking and you're overweight and you've got a family history and you've got all the risk factors, then you're more likely to have that problem. But so after the age of 60, if you've got any established blood vessel disease, putting estrogen in is like a corrosive. So it has this sort of what we call U-shaped curve. It's protective to healthy endothelium, which is the blood vessel lining, and it's corrosive if the lining is not in perfect shape. And so the problem is that 60% of, certainly in the UK, 60% of the UK population is obese or overweight. That's a risk factor for blood vessel disease. So if you add in high blood pressure, diabetes, also very common conditions after the age of 60 and increasing with age. As you mount up your age and your risk factors, if you've smoked, for example, if you've got a family history, high cholesterol, the HRT as you get older is more risky. That doesn't mean you can't take it when you're younger. It's just that you need to know when it's not going to be as good for you in terms of long-term risk. So it's about that risk balance. And again, it's my narrative isn't a great story for any newspaper or any media outlet, because I'm sort of saying, well, it's a little bit complicated. That's what medicine is. It's complicated. So some women will benefit at certain times, but not forever. But the narrative of let's just put everyone on HRT and that's it, end of story. It sounds good, doesn't it? It's a great headline, but it's just not as straightforward as that. Many women will benefit, some more than others. And after several years, the risks start to mount up, really. And I haven't even talked about cancer risk, because breast cancer is a background risk in older women. It's been an overrated risk in younger women. And so a lot of GPs will go, oh, no, you had, some distant member of your family 5 centuries ago had breast cancer, so you can't have HRT. That's ridiculous. But it's about looking at, when you're 60 or when you're in your late 50s and your symptoms have settled down, do you really need that HRT, or is that going to actually add to risk later? And it is individual. And if GPs had that extra training, they would be able to look at that risk in their patients much better.
I'm going to ask a personal question. So if I don't smoke and I do weight bearing exercises and I eat really, really well and I keep my stress down, and I came to you and said, I'm worried about dementia, cardiovascular disease, osteoporosis. Should I take HRT to increase my chances of not getting those? What would you say?
So let me just go back to the dementia risk. So the dementia risk, there's a lot of social media talk that HRT reduces dementia risk, and that is not evidence-based, actually. There have been studies that show HRT reduces dementia risk. There have been studies that show it increases dementia risk. There was a big study from Denmark published in the British Medical Journal a couple of years ago, and it was a very big study, and it showed an increased rate of dementia in women taking HRT. And other studies have shown no change. And the problem with research studies is that, as I said, they can be biased, they can be funded by pharmaceutical companies who might want to produce results that are beneficial for their sales. And sometimes, through no fault of our own, some research studies will show things that look like they might be promising and they're not. So the data on dementia, yes, women get more dementia than men because they live longer than men, is one of the things. Genetic factors are likely to be quite major in dementia risk, but also lifestyle factors. So people can have, family history of dementia, and if they keep their lifestyle healthy, that reduces risk. And it's very clear that lifestyle measures reduce risk of dementia. It's very, very clear, and that data is very robust. So insulin and high insulin levels and predisposition to sort of metabolic syndromes increase risk of late onset dementia. The early onset dementia is a slightly different ballgame, but the late onset dementia, which we're talking about, that women get, lifestyle makes a huge difference. So there is no data to suggest robustly that's agreed across all learned sort of groups that HRT should be given to prevent dementia at all. So that's so I think it's a lovely story, it's a lovely headline, but it's not a peer-reviewed, agreed through all of the sort of menopause societies that is actually fact. It's not. Should you take HRT? I would say to you that the biggest reason to take HRT where you are now is symptoms. If you feel well and you can take, you can do your lifestyle measures and you're managing your sleep and your stress and you're eating a healthy rainbow diet and all of that, then if you everybody's a bit tired. We're in a pandemic globally. I see a lot of women and men in my clinics of all ages. Everyone's tired. Everyone's feeling a bit rubbish and a bit stressed. So we've got to be careful not to say all of everything that's to do with our environment that everyone else, it's all menopause, because it isn't, because actually people who are not in menopause are feeling it as well. So it's about objectively thinking, right, I haven't slept for ages, I'm doing everything with my sleep hygiene, and I'm getting palpitations and I'm anxious and I've got hot sweats. Then if you've got those symptoms and you're doing everything you can with your lifestyle, I think have a trial of HRT to see if it helps, but have an open mind, because what women do is they take it and then they'll go, well, I took HRT and it didn't help, so it must be the wrong HRT. So then they try another one and it's the wrong HRT. And it's like the elephant in the room is that there's other things that need to be looked at. And it is a tough time for everyone at the moment. And it's not just women in menopause that are struggling. And I have lots of younger women with premenstrual disorders who are really struggling as well. And they're not in menopause, but they're getting a lot of hormone effects from stress and, other aspects of the life that we're all leading at the moment.
It's so uncertain. When it comes to the hormone therapy, I'm seeing a divide, and I heard a gynecologist in an interview on Instagram, but she was actually talking. It wasn't something someone just posted, saying that in the US, mainstream medicine is really about estrogen when it comes to hormone therapy, and they kind of add progesterone when they have to, when you have your uterus as protective mechanism. And the integrative and functional medicine world and naturopathy is very much about progesterone and what progesterone can do, and cream and all this other stuff. And I'm just sort of wondering if you could, you have this great perch to look at this. What do you think about this? Am I reading it right? Like, is she right when she's talking about it?
Well, so estrogen is the hormone that becomes deficient in the perimenopause and menopause and causes the symptoms. So the palpitations, the anxiety, the insomnia, the hot sweats. So it's estrogen deficiency, which is usually the target for hormone therapy. And in the 1980s, that was recognized. So that was a long time ago now, and everyone was given estrogen, and it was good. It helped aches and pains, it helped sleep, it helped women feel better. And then I think it was in the late 1980s, there was a few studies that said, oh, if you give estrogen to all women who have got a uterus, they get womb cancer, because the estrogen is proliferating and stimulating the womb and causes womb cancer. So they worked out then, because there's been a rise and fall of hormone therapy over much longer than this last few years. Believe me, it's been going on a long time. So then they started, and it was only in the 1980s that this was discovered. And so then they started giving estrogen with progesterone. And we worked out that if you're perimenopausal, you need progesterone sort of cyclically. You don't take it all the time. You just need it like we would normally produce progesterone in the last 2 weeks or 10 days of our menstrual cycle. So we'd give it then. And if it was a woman who'd not had a period for a long time, you can give a lower dose continuously. So we worked out those regimens. But in the olden days, the progestogens that were given were very synthetic. It wasn't natural progesterone. And then fast forward to the last decade or so, the last 15 years, we managed to find a method of giving natural progesterone as a tablet. We've been able, it's available in creams, but the absorption through the skin is very erratic. So you never know how much you're getting. So a progesterone cream isn't validated to be enough to protect a woman's womb from ovarian cancer if they're on estrogen. So we don't ever recommend the creams as a part of the standard HRT. But the thing about natural progesterone is it's an anxiety reducer. It reduces palpitations. These are natural effects of progesterone. It can make you feel relaxed, so it tends to help with sleep quality. It can reduce hot flushes. So I think the naturopaths are saying, well, this is a hormone that can give you some nice beneficial effects. It's a bit like taking a drug that helps you sleep or something, but it's natural. So why don't we give that anyway to women, even if they don't need progesterone, because we're using it as a feel-good hormone. So again, it's the complicated spin. So you need to have progesterone if you have a uterus. And if you can have natural progesterone, which we have licensed now, available widely, that's the best way to have progesterone. And also, synthetic progestogens can actually cause weight gain and things like that. Natural progesterone usually is weight neutral. It gets rid of excess fluid retention. So it's a nice sort of hormone. But, to say for a naturopath, I do have patients who've had hysterectomies, and they say, well, my naturopath said I should take progesterone. And I say, the problem with that is if you've had a hysterectomy, you don't need to add progesterone in. You can just have estrogen safely because you don't have a uterus if you've had a hysterectomy. And we know in terms of risks with HRT that if you take estrogen alone without progesterone, the breast cancer risk and the cardiovascular risk are much, much lower. The combined estrogen with progesterone increases the risk, not in the first year or two, but over a number of years. So giving estrogen with progesterone, if you don't need progesterone, doesn't make any sense, because you might be, again, it might be the feel good for now, but the consequences for later. Does that make sense?
It totally does. But I mean, they're saying sometimes just progesterone, no estrogen, because the theory is that the estrogen is rising and falling and that you don't always need.
Okay, so in perimenopause, there's a term, it's not really a medical term, they call it estrogen dominance, and it can occur in certain situations like hormone imbalances. You can get it in polycystic ovarian syndrome, where your estrogen levels are generally high all of the time, and that can cause womb lining thickening. And in perimenopause, you get these huge spikes. Not everybody, but some women will get these huge spikes of estrogen and then massive crashes. So overall, they're estrogen dominant. But the problem with that in perimenopause is that, yeah, you get the spike that thickens your womb lining, that causes your boobs to get really sore, your fluid retention, you know, and maybe migraines a lot of women get with those peaks of estrogen. But then when the estrogen crashes, which is only a few days or weeks later, you're tearful, you're feeling awful, exhausted. So it's a real moving target. So in that situation, I wouldn't just give progesterone, because it's actually, if you give estrogen, you need, obviously, if they've got a uterus, they need the progesterone as well. But if you've got estrogen there coming in from a patch or a, you know, gel or whatever, the peaks and troughs are because your own ovaries are just getting all agitated and twitchy and don't know what they're doing. One minute they're trying hard and the next minute they can't be bothered. Mm-hmm. And if you give that little bit of estrogen, it calms down those peaks and troughs of your own body producing it. So you get less migraines, actually. So people say, oh, you know, don't give HRT if somebody's got migraines. Actually, it stops these terrible fluctuations in hormones. So no, I wouldn't generally give progesterone alone as for menopause symptoms. I might give progesterone in somebody who's perimenopausal, who doesn't have terrible symptoms but is having a lot of dysfunctional bleeding, because the progesterone helps with the uterus. It's anti-proliferative, so it stops the womb lining from thickening and it allows it to shed properly. So there are situations where we do use progesterone, but not as a naturopathic, let's make us feel better. It's specifically for, you know, what progesterone is needed for, which is to clear the womb lining and, you know, stop it from causing, you know, random erratic bleeding.
Well, I could talk to you about this all day, but I'll ask you one more question, which is, what is up with these symptoms? Because it's when you Google, it says 34, and then people say 40, and then there's apps that have 60, and then I heard 80, and then I think you said the first time we talked 100, and I feel like it could be like, just this week I realized I often have like a really slight sore throat, and I always think you're getting sick, you need to sleep. And then I Googled, and there were a whole bunch of people saying it can be a symptom of perimenopause, and I'm like, there's another. You know, so how many do you think there are? Will anyone ever decide?
No one will ever decide, because again, as I said, all of our bodies are different. So, you know, there's a lot of symptoms which are very tightly linked with menopause. So many women will get those symptoms. Right. And then there's a lot of symptoms which, you know, somebody said one to me recently, and I said, I've never heard that as a menopause symptom. But I said, if it's only come when you've gone into menopause, and I went through everything else, there was nothing else going on. So it was obviously relevant. I can't remember what it was. It was something quite strange. And I would say, you know, anything goes, because your body is going into balance. And if your body decides, it can throw out any number of different symptoms if your body's out of balance. And the thing is, you know, if that symptom is severe and it's very clearly menopause related, then you need to try and address it. And sometimes HRT is the best way. Sometimes, you know, just rebooting and rebalancing lifestyle is good. But I would never sort of say, dismiss somebody and say, no, that's not menopause, you know, because actually symptoms are real. And if it's not attributed to anything else, then it's attributed to menopause. So if you've got itching all over your body, so there's something called formication that many women notice. It's a relatively rare one, but it feels like insects crawling over the body, and there's a few things. But you know, something like a thyroid problem can do that. So I would always say, look, if you've got a symptom which is a little bit concerning, like itching skin or something like that, you need to check that it's not something else that could be treated differently, like thyroid problems or something else. But generally speaking, these multitude of symptoms that it'll be an infinite number because every woman will experience the symptoms differently.
So stop trying to count. I'm going to stop.
Don't count.
That there would be some sort of board that would issue like a little thing you could read and then you could look at it. Because you worry, right? Like every symptom you worry, and you don't want to go running to the doctor every single, itch and scratch and tingle that you get. But
well, on that, I mean, I think, and that is a problem today because, you go to your doctor and often people just get told, or they just get the glazed look on the doctor's face. And the thing about symptoms, if you get a new symptom, which is very progressive and changing over a number of weeks, or it's a sinister symptom, like, for example, a seizure that's new, or a collapse, or if you suddenly have severe one-sided headaches, or a new headache, or you're tingling in one arm, or your leg is not moving. Those symptoms we call, or significant weight loss, for example. I mean, women tend to gain weight in menopause, but significant weight loss, or new visual disturbance. There's certain symptoms we call red flag features, and you'll probably have an idea. So weight loss or something really quite dramatic, then you need to see a doctor, and that would need to be investigated. But the majority of symptoms with menopause are, as you say, quite non-specific. It's like, oh, well, that's there, and then it's gone, and then it comes back 3 weeks later, and it's not progressing rapidly over a number of days or weeks. So it's about working out what's something that should be a red flag and what's not. It's easy for me because I'm a doctor, but sometimes you can become hypervigilant when there's lots of symptoms. So the more symptoms there are, the more hypervigilant you are, the more you notice them, and then suddenly you've got 100 symptoms. So, and if you've got 100 symptoms, usually the doctor would be able to look at you and say, this is what's wrong with you, if it's not menopause. So that's all I can say about that, really.
Okay, well, thank you so much. This is really